Welcome, everyone. Thank you for joining this panel discussion. My name is Warren Yamashita. I'm in family medicine and addiction medicine in Los Angeles, but I'm very excited to introduce our panel. And I think speaking of this topic of health partnerships between clinics and the faith community, we really wanted to just demonstrate that by not only the panelists, but even just to bring you all into the conversation too. So one way you can do it, I know I announced earlier, but you can text questions. There's going to be a number throughout the slides at the bottom of the screen. So you can text your questions in. I'll be browsing them as we go and trying to answer as many as I can. With that, let me start by introducing our panel. So we have three clinics or three regions represented. Lawndale Christian Health Centers, as you all know, FQHC in Illinois. So Dan Wegman is a certified peer support specialist who's been working closely with the clinicians and the recovery community. Well, let me just read your bio. But working with individuals with varying degrees of mental illness and substance use disorders. He has over 12 years of experience in this area. And he also has a Bachelor of Arts degree from Moody Bible Institute in Pastoral Studies and seeks to integrate the Christian faith into his work with those he serves. Dan currently serves as a recovery care coordinator at Lawndale. From Esperanza, we got a big team here in Philadelphia. So we have two Sams, but starting with Samantha Baker Evans. She is a family nurse practitioner and associate medical director for substance use disorders at Esperanza Health Center. She worked in addiction, mental illness, and HIV care for the last 26 years in the U.S., Australia, and Cambodia. In her non-medical life, she's also an artist, mother, wife, daughter, and neighbor. We have Zachelle, who is a certified recovery specialist serving at Esperanza for 2 years, who grew up in the Kensington area of Philadelphia. As a person living in recovery, she is passionate about advocating for all pathways to recovery, including behavioral, pharmacologic, and spiritual interventions, which were imperative to her own recovery journey. She is a proud mother of one beautiful daughter. And the other Sam is an internal medicine and addiction medicine trained physician at Esperanza, who's originally from New York and grew up in Kyrgyzstan. He completed his medical training in Virginia. Yeah, okay, and his residency and fellowship in California. He's grateful to be in Philadelphia along with his two sisters and niece. And the third region is a Ohio Medical and Church marriage partnership with Dr. Beth Delaney, who's a DNP and Chief Wellness Officer with Her Story, and her husband, Pastor Greg Delaney. Both of them have been really voicing addiction care and needs at CCHF for a long time. So with that, feel free to text your questions in, but we prepared some questions in advance. So I'll start off with the first one. Bridging the silos. It's been said that the opposite of addiction isn't just sobriety, it's connection. In what ways have you seen clinical, faith, and community sectors unintentionally work in silos? And what specific mindsets or practices have you found most effective in creating truly integrated care for those battling addiction? So if anyone feels led to, feel free to hop in.
I'd say one area that we feel sometimes there's when people are very passionate about what they do, as they frequently are in addiction work, they sometimes get very strongly opinionated about what is the most effective way of treating a patient. So sometimes it feels like we're standing in the middle of like a church that believes in abstinence only treatment or 12-step theory or versus a harm reduction versus medication assisted therapy. Do you want me to? I may not have
Thank
turned it on. Hold on. Can you hear me now?
Mhm.
All right. Yeah. So sometimes there's differing opinions in what the best treatment is, and I think one of the things that we've tried to we'll have churches that are very against us using Suboxone or buprenorphine based therapy, and then we'll have other organizations that are only want that and don't believe in cognitive behavioral therapy for these patients, or are against 12-step groups, and it can feel like we're kind of in the middle of that. And I think one of the kind of our or my thought on it is that when we're treating cancer, we don't use just one modality, and that recovery is a whole person process and needs whole person interventions and high quality interventions. And so I think we've strived to do. I see my team in the front nodding. Thank you guys. Yeah, they agree with me. That offering patients a range of high quality interventions is appropriate, and that it's not necessary that these things be in competition with each other.
And I think also what I was surprised by, and maybe you would be too, is that when I came to her story, which is a small recovery house in a small organization in Xenia in Springfield, Ohio, we've merged. So we have the continuum across from the moment of recovery through recovery housing, is that oftentimes the faith-based, or the ones that I've worked with, the faith-based organizations in the community, sometimes when you talk about the electronic health record, that's another place where silo, very clear. And I came from the background of being a nurse practitioner for over 30 years in large academic and large health systems. So to come to a place where I'm asking for the problem list, the physical problem list, and these very well-meaning, knowledgeable, super smart clinicians in the mental health world are looking at me puzzled, was a surprise to me. So that would be, I don't think it's a purposeful silo, but definitely one that we need to shed light on and educate one another about the benefits of integration. Because like what you just said, Sam, I mean, we can go on and talk about that, but not even have one where their medical records or their goals are not in sync between medical care, mental health care, and spiritual care is definitely a silo that I've observed.
Yeah, I think just kind of piggybacking off of that, I think the first thing that I thought about whenever Warren asked this question is I think about some of the patients that we work with, and just realizing that our patients are multifaceted, right? They have all kinds of different aspects to their lives. They're not just one aspect. And I think a lot of times in these situations where you have these different organizations or different entities, is they're trying their best to try and address the need that they are most qualified to address, right? But those entities rarely interact and communicate with each other. So one of the things that we try to do at Lawndale is we try to the best of our ability, to try and like put all of those services, not a church, but the faith component is definitely there, and try and put all of those things under one roof. And like there's different members on the team that specialize in those different areas, and that we can like walk across the clinic and communicate with each other and to have conversations. And really, I feel like it's the best way to really help the patients and to be able to address all of the different facets of their individual lives.
I'm gonna piggyback off of what Warren said. I'm gonna speak on my personal experience as a recovering addict. I actually used to receive services at Esperanza. I used to be a patient there. And one of the unique things about Esperanza is that I was mind boggled of a facility that was faith-based, which is very rare, where they combined your spiritual, your health, your physical health, and then your behavioral health portion of it, mind, body, and spirit, soul. You know, like that was very unique. And it's something that I appreciated too. One thing that I admire too is seeing different departments come together to serve as one patient that is in active addiction. So at Esperanza, we have social services that come together with the medication assisted treatment program. Somebody is running around grabbing a hygiene kit, the other person is assisting the patient with finding them a shower. So I find it to be very important to combine all of these things together for patient care.
I wanted to kind of use this question and take a quick poll of who's in the room, to see, what organizations you all represent. So, for those of you who are working in a clinic, if you could raise your hand. Okay. And then anyone else hand not raised? Was out anyone with a church or pastoral background? No. So, what type of organization?
I'm another probably, but I am the healthcare coordinator for a homeless ministry that is a conglomerate of 9 churches.
Oh, awesome! Yeah, thank you for sharing. Well, and then those in the clinics. How many are medical clinicians? Okay, behavioral health. Awesome. Any other peer recovery specialists or recovery coaches? And how about administration or leadership? Okay. Did I miss any students or residents? Okay, awesome. Well, thank you all for joining. I think related to this question, again, thank you for texting in some questions. Some questions came in related to how to activate individuals. For example, individual nurse practitioners or physician assistants to begin prescribing. So we have 2 nurse practitioners here, but also another question that asked, how do we partner with churches or even activate pastors in our community? They asked, for example, what are some best practices to connecting, like cold calling, or so maybe Pastor Greg, if maybe we'll start with the nurse practitioner, PA, and then go to the pastor partnerships.
So I'm also a person in long-term recovery, been 16 years, and had found my journey of recovery through the church. And it really was that integration of a pastor who kind of understood me because he had been through it himself. And so we began and built ministry that a lot of churches will build. They'll create space. So AA meetings, Celebrate Recovery meetings, those kind of things. But here in Ohio and beyond, as we continue to kind of grow out and seeing that the opportunity for pastors sometimes is seen that that's an outreachy kind of thing. And what the truth of the matter is that the math, especially here in Ohio, for example, 1 in 13 people have a substance use disorder here in Ohio. And so those folks are in your church. And so the conversations that we have with pastors is that your church needs to be prepared to be able to intersect and work and care for and love people and their families who are dealing with substance use and mental health issues. And so as a part of Recovery Ohio, which I'm a part of with Governor DeWine, we have something we call recovery-friendly congregations. And so we spend time creating a curriculum that's not too clinical, but clinical enough to help bring in Addiction 101, Mental Health 101, some trauma-based care conversations for pastors and lay leaders. And then at the end of that, what we really try to do is help them have 3 R's. We want the church and those leaders to be able to recognize what substance use and mental health is and what it is appropriately, not what I've stigmatized it to be or what my opinion might be about it. How do I respond based on what I have inside the house? So a church of 25, their ability to help might be to provide food to the recovery house down the street, or a giant church may be able to have, a recovery response team. They might be able to open a house, those kind of things. So we help them within their own capacity, how they respond. But the key piece that's this part of this conversation is then also helping them to understand the need for referral. And when you're over your skis, this is how you connect to the infrastructure that you have within your community and who those providers are. And then we help to kind of pull those 2 things together. So we know who the good providers are. We want to make sure they know who they are, and then how they go about referring someone in and out of that. And so they become a place that understands, a place where someone can begin a recovery journey, a place that could also support. So while Beth is off into her treatment, what am I doing as a church? I continue to have the opportunity to write a letter, continue to pray, continue to come around the family, those kind of things. Then I have a place that I can return to and belong, and then a place where I can grow. And so that's kind of the way that we have reached out. And so we just try to create space, just kind of letting pastors know there's a place for you at the table with this. And that's how we've done it here. And the good news is we build a toolkit with Health and Human Services. I can direct that through Warren to everybody that's here on how to do this, as well as, some other ideas from other states. So we've got some great partners on intersecting, how to have the conversation, that sort of thing. So hopefully that answers your question.
Yeah. I'll have my email on the last slide, and we can connect you to any of the speakers if you want to follow up. Related to the clinician question, they also asked, not only how to activate some of the providers to begin prescribing treatments for addiction, but also referring to psychotherapy for addiction, especially in resource-limited areas without as much behavioral health.
Well, I think in terms of training, we just recently ordered all of our providers to start. So I think most of us were not equipped well in our medical training for treating addiction. I think that's changing. The students who come to us seem less surprised that, or our newer clinicians seem less surprised that that's going to be part of their role at Esperanza than those of us who are older. So I think that's a good change. Still, the opioid epidemic is very different in different cities, and so understanding your really specific context. In Philadelphia, we're dealing with high amounts of fentanyl, carfentanil, and xylazine, and the new that one. And so prescribing for that looks very different than other regions, and what we found was a lot of the times the training was not relevant to our context. So we partnered with Health Federation, a group of FQHCs in Philly, and they developed training specifically for our providers. And so all of our providers do a half-day training on prescribing buprenorphine, particularly for in the context of fentanyl, including the long-acting injectables. Not all of our providers then go on to do our MAT group sessions, but our goal is that all of our providers would at least be able to initiate buprenorphine when they encounter a patient that needs it. We also do yearly training on overdose prevention because we have a lot of overdoses outside our clinic, and we have a overdose response team. Our security have particular walkie a team to come and respond to overdose on the streets around our clinic as well. And I think the training, giving people additional training, relieves the anxiety of feeling that you're practicing beyond your training. So that's been the main other.
I would just say the power of the training. What I've really had experience with when I've been talking, whether it was a family member, a nurse practitioner, a client, is helping them understand. And I'm sure, Sam, you could probably attest to this too. When a person can understand the physiology of the brain, making sure that people understand that the addiction changes that happen with the brain itself, the physical changes, and helping, whether it's a clinician, a family member, a client. Oh my gosh, we could talk just the whole rest of the time about how that can be effective. And a tool that literally all I can say to you is the Holy Spirit. Like probably about 7 or 8 years ago in summer when Greg and I were out, my father had severe alcohol use disorder, and then I ended up having alcohol use disorder pathway with Greg. And that's another story that I'd love to tell of God's amazing grace and redemption. But, in the Gospels, Matthew, if you look in the Gospels, what's the greatest commandment? What is it? Love the Lord your God with all your what? Right? Mind, soul, strength, depends on whichever translation. So if you're sitting in it, I have found that if I'm educating people about brain science, and then if I'm in a more Christian organization or space at that moment, just putting the scriptures up that Jesus showed that a human is a body, mind, spirit, or whatever. And I'm not talking about theology. I'm just talking about that there's more than one dimension to our humanness. So why wouldn't we want to help train and empower and give tools to all parts of that as clinicians, as giving understanding to family members and to clients. And then I can tell you, I've been in those rooms and spent an hour talking about brain physiology and then talking about Jesus, talking about that. And I can see the barriers of some people that have strong convictions about some of the things that if you're in it every day, and they just kind of stopped. And you're like, they just got it. And we've also had moms and family members break into tears because they realized that their loved one was in addiction because of these things, not because they didn't love them. And so it's been a powerful little 2 nuggets of education that have really helped to bridge some of those different spaces.
I think the last thing I'll say is that, and maybe I'm from a different generation, but diabetes is not optional as a primary care doctor, and addiction care should also not be optional.
Correct.
There's a lot of stigma associated with addiction, and we as Christians need to be the first ones to tear that stigma down. So we'll talk more about stigma in a second, but I don't think there's any excuse to not be seeking training if you don't have it to provide addiction care in the primary care space.
Yes.
And I do think team is really protective against burnout and from being overwhelmed. I don't have to be an expert in every aspect. I have behavioral health staff and recovery supports, and you don't feel overwhelmed when you have a team that's working on the same thing. Yep.
Great. Yeah, it's such a good discussion. If you're able to text in your questions, but you want to, yeah.
Did you have pushback from providers when you just said it's mandatory? Did you have pushback in your saying, "Nah, I'm not going"?
I haven't.
So,
we're not requiring them. So we put our behavioral health staff always with our MAT patients. So every time they come in, either for an individual or a group appointment, they're seeing a behavioral health provider or a peer specialist.
Are you talking about the clinicians?
The clinicians.
A pushback from clinicians?
Change management takes time. And so we didn't do it the first year of our program. We did it the 5th year. And we did it at the point that also we actually delayed it because of the pandemic, because I talked to providers who were not mood providers yet. And one of them said to me, I feel like I can't take on another learning curve right now. And I listened to that and I delayed for 2 years. And then I talked with the leadership and said, I think we're ready for this. So we're requiring them to do the training. We're not requiring, and eventually they'll be required to initiate buprenorphine with the support of behavioral health staff if a patient is there. And we're giving them a home detox guide that goes through initiating buprenorphine so that they have that when they're going over the patient. So it's not just something that they have to, after 6 months after training, all of a sudden pull out of the hat. And so, we're trying to resource it as much as possible. Our team is on a live extension, so a provider can always call to get team support, even if they're not at a site where the team is that day. So we're trying to support it, and then went slowly. And then this is the year that we kind of said, so far have you heard any? So far it's been like, yes, we've been wanting this, and I really have wanted to know about that. I think we are extremely immersed in the opioid epidemic in our setting, so it's not, no one's arguing with the need. You've probably seen us on the news. Yeah.
Yeah. Great. This is such a rich conversation, and someone texted in a question about recommendations on addressing burnout when working with patients with addiction. I just wanted to highlight the response of how a team having that can be an antidote or help buffer against burnout. And we chose reached out to each of these clinics because they do have experience working as teams. And as you can see, I just wanted to highlight just those that we have 2 peer recovery specialists and people in recovery, and recognizing that people in recovery are very important to integrate into your teams and conversations, and how your clinics and even church organizations are responding to addiction. There's people sitting in the pews and staff just waiting to be heard and activated. One more part on teams, and maybe even supporting other providers or even pastors getting plugged in or into these collaborations or starting to treat or prescribe medications for addiction. I did include this QR code. Part of our collaborations through this this ARISE collaborative. It stands for Addiction Recovery Integrated Services Exchange, where we're partnering with CCHF community. There's also CMDA, the Christian Medical and Dental Association, and other churches and organizations across the country to really support each other with trying to not only build our own organizational capacity to address addiction and promote recovery, but also bridging these silos and collaborating with across sectors or even within the healthcare system. So we meet monthly. We have a monthly Zoom gathering. One of the hopes we have with this panel is to just cast vision and hopefully share that none of us have all of this figured out. And so we want to even support each other. I know each of their programs have been speakers at our monthly ARISE sessions over the last couple of years. So we invite you all to join, especially as you're brainstorming for yourselves. Okay. Go to
Hey, Warren.
Yep.
They have one of the things that Her Story does for burnout, which I think is useful, is we have a couple of days every year, and we just call mental health days. So they're not part of your vacation, they're not part of your sick time, and it's only like, I want to say 2 per year, but you can just call in that card, and the team is completely supportive of when you call in and say, I just need a mental health day. And I think that, they're not used very often, but the fact that you can use them is useful.
I would like to add something. I feel very grateful to have the team that I'm working with. One of the things that helps with burnout is that we have retreats where we all gather together, all staff, we come together, we praise God, we share our testimonies, we share victory stories that we've had with patients. We have the behavioral health department available, that they're always there to, help us out. We have the security available for when one of the MAT staff needs to go down to speak with a patient, just in case de-escalation is needed. We have social services department that works very close with MAT. Although we provide many of the same services to different populations, we share resources, we exchange information. We have support group chats with the behavioral health, MAT, and social services where we uplift and encourage each other. We have devotionals every morning just to take that time to spend with God before we begin the workday and allowing Him to be present in our patient care. So I feel it's very supportive. And yeah, thank you.
We had one of our hospital systems in the greater Dayton area, faith-based hospital system, Kettering, was recognizing some of this in the space of burnout and how to create safe spaces for people that are doing the work and having conversations around mental well-being. And so they actually funded a project where we created a Vimeo channel where you have I think we have 18 videos where we kind of go over a topic that's around our mental well-being, and we create a small group sheet. So 5 or 6 of us just getting together and, we kind of watch a little bit of information. But what happens is in the conversation, it becomes really rich. And in that conversation, we have this opportunity to be authentic and just be there for one another. And coming out of that, what we're seeing in the greater Dayton area is this movement toward, whether you're licensed or unlicensed or whatever, if you're a practitioner of what we'll call soul care, we're actually being very intentional to try to bringing all of those people into the same space. We're going to host something on the 17th of May where we just want them to know that you're not alone, that there are others in this space that are doing this work, and we're creating just a collective and a collaboration around that. So that when I come into this space and when we do this event, it's not a keynote, it's not anything. It's just giving our folks a chance to learn and be with other folks. who are doing this work. And then coming out of that, we'll equip them further on down the road. But it really is this whole notion that we're so much better together than we are apart. And so creating spaces and opportunities for conversation so that we can help those who really do often. And I know I would bet in your position, being the navigator, it gets lonely because you're pouring out every day, all day into this, and you don't have that on the back end coming into you. And so that's part of what we're working really diligently as a part of a kind of a unifying Dayton effort. So you have your 9 churches that come together to do that. We're trying to bring churches that have a kind of a compatible vision for this kind of stuff, but then saying within there, how do we create space for them to just really care and love on each other? So another area to keep that wellness up.
Great. We're going to pivot to this idea of stigma. So the invisible wall in the exam room, where stigma sometimes manifests in subtle ways in clinical spaces, maybe even church spaces too. So for a panel, how can clinicians or even, how can clinicians be trained to recognize and remove subconscious biases towards people who bring faith into their recovery story and who might not fit the expected mold of a patient, for example, like treating addiction with medicine? How do we integrate faith into that, especially at CCHF, where we're really integrating spiritual care into our how do we do that with addiction care?
Maybe I can start. One of the things that I've seen, and it's kind of interesting having trained in San Francisco and now being in Philadelphia, there's some cultural and religious differences as well. And I currently work predominantly with a Latino population that have a lot of Christian backgrounds as well. But one of the things that I thought was interesting is I realized that maybe inadvertently, a lot of people that are coming from church backgrounds carry maybe an extra layer of shame. And I think one of the most common things that my patients kind of work through with me is this idea of replacing a drug with another drug. And they share that that's something that was shared a lot in their church spaces, and how their recovery with being on a medication for opioid disorder like buprenorphine is not considered real recovery because it's not pure abstinence. And so you're still living in sin. And so a lot of times we've had to like work through some of that together. And I feel grateful that my patients have invited our team to speak about spirituality like that and be able to kind of share my own kind of theology and beliefs about that. I think my strong belief is that addiction is not just a physical dependence on a substance, but it also is the chaos that follows it. And what I tell my patients is that when we give you this treatment, we remove that chaos associated with that substance. And so in many ways, I mean, we'll talk about recovery too, I think later too, but and being able to provide like maybe a little bit of a different philosophy and has been really meaningful and has led to some really important conversations as well. And I think what's really powerful is that we have group therapy, and a lot of times our patients then kind of dispel those myths for our newer patients, and seeing that stigma being brought down has been really powerful for me to witness as well.
I was just going to say, I'm not a clinician, but I think this is just my shameless plug for incorporating peers into teams. Because it sounds like that's happening organically. Like, yeah, patients are kind of coming alongside other patients and kind of like sharing their stories and kind of helping dispel some of that. Like having like a peer on your team can kind of professionalize that in a way to where I think that a lot of times is what really kind of like tears down walls and barriers is people's stories. Is whenever somebody hears somebody's story, that can be very disarming, right? It's not just coming at a person with statistics or science, like there's absolutely a time and a place for that. But I think sometimes stories is what can really like help bridge a gap and can really form connection. And as a peer, that's one of my favorite things is to be able to be a walking, talking billboard for recovery being possible and to be able to hear for people to be able to hear my story and to be able to kind of infuse the space with hope, and then all of the various different tools that are at their disposal, and to be able to encourage them to be able to use the various tools that are at their disposal.
I agree with what Warren said. It's very important to include the peer portion of it, because providers and behavioral health consultants, those that have a behavioral health background, they understand, like the science behind it. But I have the personal experience. I can help advocate for the patients. I can tell you that BUP induction is important. I can tell you that I've been, discriminated by Christian-based facilities because MAT is not an option. But the thing is, it's so mind-boggling to me because there are diseases that are caused through poor decisions, one of them being diabetes. So why can't addiction be one of them? Are they not worthy of treatment? What makes them not worthy of treatment? So what helped me understand treatment a little bit better was, my therapist at the time, and was having a peer person telling me, you're going to go through this. This is how you're going to be feeling. And I couldn't understand it. But once I started going through everything, I'm like, wow, like they were on point about everything. And, I got to understand what was going on with my mind, with my brain, that it was changed due to having these chemicals, these substances in my body. And then I got to understand, what recovery really is. I didn't know. I gained the tools to maintain my recovery from peer support. I don't want to hear from a provider like, who are you? You've never been through anything that I've been through. You don't know my struggle. But I'll sit there and listen to somebody else that went through the same thing that I did. And then I'll listen to the provider because they're telling me their experience with the provider, with the program. So thank you.
And Warren, as us providers, I feel like we have the opportunity to get trauma-informed language and then share that. And so when you hear people and they're not like scriptural or when you hear things and you feel like it's stigma, instead of not saying something, have a kind, appropriate, trauma-informed, scripturally based conversation. And that's what I found is myself using trauma-informed language. And then when I hear, and I'm new at this in the last few years, but when I hear someone else do it, I can't imagine, but I bristle now. And I'm like, hey, do you, and usually if we're kingdom brothers and sisters, at least there's an openness to conversation. So do not ever forget that you as a provider can be in your community, can be in your church, because you're respected. And so when you come there and you have trauma-informed things to say and learn, and you can teach people, just by virtue of your position in the community, maybe you'll be able to have some impact that you maybe hadn't really thought about before.
Great. I know that we have jumped into a lively discussion, and I also recognize that maybe some of us here are not familiar with some of the acronyms that we use. I just wanted to touch on the acronym MAT or MOUD, Medication Assisted Treatment. The American Society of Addiction Medicine is trying to really encourage us to use medication for opioid use disorder. The main point there is that we want to destigmatize addiction care so that, we wouldn't say insulin-assisted treatment for diabetes. No, insulin is just treatment for diabetes in the same way Suboxone is treatment for opioid addiction with a number needed to treat of 2. Some of the questions were also talking about, how to help patients engage in not only MAT or MOUD treatment, but behavioral health treatment. So I think the important point there is even in a BH limited setting, MOUD treatment shouldn't be withheld just because the BH services are not available. And then to really kind of highlight what the panel shared about, maybe in areas where there's less behavioral health services, there is definitely a lively and rich recovery community everywhere, even in the rural setting. And just to highlight, there's a Cochrane review in 2020 looking at 12-step groups in Alcoholics Anonymous, and it found that Again, Cochrane study is just the highest level of evidence, finding that it is evidence-based for addiction treatment. So there's definitely that resource in your community. There's a NIAAA 12-step facilitation manual that's publicly available. If you Google it, it's a manual that was created by the National Institute on Alcohol Abuse and Alcoholism that walks providers and clinicians on how to facilitate and encourage patients into 12-step groups within their community. So, love the conversation. I'm going to pivot to question 2. As we've talked about acronyms, with addiction care, there's a lot of new language. And if we're bridging silos, we also have to bridge the language. Doctors and clinicians sometimes talk about addiction different than pastors. And so this idea that recovery is more than abstinence, actually, Dr. Delaney often has talked before in previous CCHF talks about recovery as the pursuit of wholeness, not just the absence of the substance. So how can clinicians and ministry leaders collaborate to redefine recovery, not simply as sobriety, but as a pursuit of wellness, purpose, and connection? And to touch on a couple things mentioned earlier, how do we have those complex conversations where we're not only sharing about the neurobiology of addiction, but we're integrating that with trauma-informed care. We're integrating that with scripture. How do we talk to a pastor about addiction? How do we versus maybe a layperson?
So I think on the pastoral side of it, when we talk about trauma-informed language, I'm sure many of you in here know it's not a question of what's wrong with somebody, right? It goes back to what Dan was saying. It's not what's wrong with you. It's what happened to you. And so creating space to have the conversation about what happened to you. And so when I'm working with the pastoral community, often I don't need to get into the weeds of whether, someone is, dealing with a substance use disorder with an opiate or alcohol or whatever. We know that there's something going on in their life. And I think what people sometimes don't realize is that we look at the addiction and we say, well, that's their problem. It's not. That's their solution. And so I have a thing going on in my life, whether it's depression, whether it's trauma, what it doesn't, all of that's there, right? And I found this thing to help me navigate that. And in my case, it was affirmation issues. I had issues with stress. I had issues with depression, and alcohol early made that better for me. And then at a certain point, then it didn't. And then the chaos that you were talking about, that came along with it. And so I think when we're looking into the faith community, what I kind of do to diffuse it is I can tell you all about the science. I can tell you what's going on in somebody's brain, and I can do that too. And we've got that distilled down to where we can do it in 3 minutes with a really effective video that I've watched hardcore, arms crossed, this is just sin pastors in a room. And I show that video and suddenly they are convicted because they are wrong. And they are like, oh my gosh. And like Beth said, with families, they see that. And when I learned what was going on in the survival center of my brain with alcohol, I kind of learned all this in 2009, 10, 12-ish, maybe, had been sober for a minute. It gave me the capacity to forgive myself. Because I was a church guy and I shouldn't have been doing this stuff. And I had made these choices and I had put my kids in danger. And suddenly when I started to learn that part, and so there's a blending of that, but often when we're leaning into how do I have that faith-based conversation, it's you're already equipped to lean into with your discernment what could be going on with someone. Don't get so fixated on how they're trying to cope. Let's bring it into a context where now I'm wanting to offer you a different way to cope. And I'm going to walk with you in this, and I'm going to give you space, and I'm going to be a good listener so we can start to figure out what really is going on that's led you here. And oh, by the way, I'm also going to get you the help for what's here. And so we're going to connect with some really wise clinicians that are going to help settle your brain down and help you to be able to have the conversation so we can get to the root, what we call the why behind the whatever. That's where I want to go. So that's been some of our strategy for that when it comes to the faith community.
The video, what's the name?
So the video is from a group called Addiction Policy Forum. It's on YouTube. It's called The Hijacker, and I've probably shown it 300 times. We have a great partnership with their founder, Jessica Halsey-Nichol, who just wrote a book on navigating addiction for families. It's not a faith-based book, but going back to all this shared experience, what our beautiful colleague down there has talked about her journey, Jessica has the journey of a family member. And so she's written a very insightful, blended, sciencey experience kind of guide to helping families. She actually created a curriculum that we shared here in the state of Ohio with over 1,300 people called Encompass. And it was really just to help folks like you, help folks that you're dealing with and the families that are navigating this. So don't want to take up too much time, but.
Great. Anyone else?
Maybe just, I just wanted to share, I think one of the most, I'm not a big reader, but one of the most life-changing studies that I was able to read was a qualitative study from 2023 where people just interviewed different people that are living in addiction or had a history of addiction, asking them what recovery meant for them. Mm-hmm. And from a medical perspective and public health perspective, like our outcomes are largely reduce overdose deaths, reduce hospitalizations, reduce ED visits. A lot of them come from like reducing mortality and reducing cost. And this study showed that what people cared about was reintegrating with their family, getting to pick up their kids from school, going back to school, starting a job again, being housed again, and all these things that I think kind of capture living a life abundantly, which I think is what Jesus wants for us as well. And I think that really changed how I viewed recovery and I guess the goal of treatment for addiction. And it's about allowing people to have the space to like reintegrate into their society and to live abundant life, whether that involves complete abstinence from all substances or not. I think that is how we've been measuring success and joy for this person.
And if we believe that God created each one of us, which he did uniquely, he knew us in our mother's wombs, we all have purpose that he puts right in front of us. SAMHSA, substance abuse, mental health, subversive impact. Thank you, what he said. They have a strategic goal, a strategic plan, and then they have 4 things that they hope for a person in recovery. And when we talk about kind of if we said back to the cancer diagnosis or the diabetic diagnosis, when their A1C gets down to 5.5 or 6 point, great. But what are we doing then? We're trying to change their eating habits, their exercise habits. Hopefully those have contributed to the drop in the A1C, but it's about becoming whole and well, not just taking care of one part of their body, mind, and spirit. And so SAMHSA says that their current thinking is if every person in recovery had a purpose, a community, their health, and a house. And when I looked at those when we were been working in the area of wellness, I think from our perspective here at CCHF, I would add hope. So I would add another H. And so it would be all those. And then if you think about what you just said, Sam, I mean, that's an easy way to write a curriculum or a recovery plan or whatever. Like you can say, have you thought about your purpose? How's your health? We've talked about sustainable housing and transportation and all that. Those are regular things in all of our clinics every day. But that might set a mini framework for trying to give a person a whole perspective of wellness and health, not just let's try to figure out why you are just like stop drinking. And it's just broadening our perspective. And we have the blessing of having Jesus in our life and the use of the Holy Spirit. So I like to try to think about maximizing those things.
Great.
Yeah, I think the thing that comes to mind for me is the fact that anybody that pursues recovery, it's because they decide they want to do it. And I think anytime you try and mandate somebody to do something that they really maybe aren't ready to do, or maybe they're afraid to do, or whatever it might be, it won't work. So I think it's about trying to create places where people can come and struggle, really. And I mean, I think that's the church really is that as well, right? Like all of us, maybe the majority of us don't struggle with addiction, but I would venture to guess that every single person in this room has something that they struggle with, some sin that we struggle with, some belief that we might struggle with or whatever. And I think that's the church. There's the old saying that the church should not be a museum for perfect people. It should be a hospital for sick, broken people. Right. And I think like that's what we should try and embody. We should try and embody a place where people can come and struggle. And that even if people come and they're just like, I'm scared to stop using, or maybe I don't think I'm ready yet, to not say like, well, you have to do this, but to say, I'm going to keep loving you, even though you have, maybe you haven't decided to do that. And I have found that many of the patients that come in our door, the big problem is they don't love themselves.
That's good.
And they want the more that you continue to love them, continue to accept them, even though they may not be making the choices that we think they should make, that they start to experience like maybe I am worthwhile because they think I'm worthwhile. Maybe I can do this because they believe in me, right? And that's a process that doesn't happen like right away. And sometimes it takes time. And sometimes, I mean, I've seen it happen before my eyes, that somebody comes in and they have no desire and they're just like, I'm just here. The only reason I come here is because you guys give me food, or you guys do X, Y, and Z for me. That's the only reason I come. But then I've had people tell me down the road, like, I keep coming because you guys keep loving me.
Mm-hmm.
And so many like names come into my head right now whenever I think about that. And I just think that is what I think Jesus would want us to do, to keep loving people, even if they don't necessarily make the choices that we think that they should make. So yeah, anyway.
And I
Right.
just want to underline and highlight what he just said, because I think that's so important. Yeah. And I'm tearing up because I think shame is toxic, and they come in with so much shame and they do not need more condemnation. What they respond to is love and kindness, and they keep coming back because of love and kindness. And yeah, and that has to be the core of any intervention.
Yeah, I know we're nearing the end of our time, so I'm going to pivot to this idea of harm reduction related to, Dan, thank you for sharing this idea of loving people where they're at, because I think the reality that we all struggle with is that sometimes Christian clinics and churches are the places that make people struggling with addiction the least welcome. And I think that's just sometimes a hard reality. At the same time, like we talked about, this idea of recovery, wholeness, relationship, restoration, community, we need the church, we need the community. And so trying to bridge this disconnect. And whenever we talk about collaborations or de-siloing, this conversation of harm reduction comes up. How do we as Christians conceptualize, understand, and communicate harm reduction? How do we think about it in terms of grace? So harm reduction is this evidence-based practice that views the reduction in harms related to substance use, or the reduction of the substance itself, as a benefit in of itself. Has a number of interventions just to complicate the conversation more, I'm going to throw out this idea that's been even discussed, that there's even maybe two philosophical lenses, a libertarian versus a progressive harm reduction, that floats out there and oftentimes is confused. So maybe if one person can speak to this, and then we'll have one more question as we finish the time. But how can clinics use harm reduction practices to reduce stigma and improve care for patients with addiction? And then if you have any like practical examples of how that is done in the clinic, or like even with urine drug screens. So actually, this is maybe a couple people, if they can speak on this.
And I would say I'm a fan. Thankfully we serve a God who doesn't hold us, doesn't submit us to the consequences of our sin, and I put harm reduction pretty firmly in that bucket. And I'm also an HIV provider, and I would really like to end that epidemic in our lifetime, and harm reduction's the main way that we can do that. So,
the faith community has struggled, if you can imagine, with harm reduction. See it as enablement, all kinds of things. But sometimes I distill it down to say, you're going to go get in your car and you're going to put your seatbelt on. That's harm reduction. You're making it kind of something that it really shouldn't have to be made into. And so we've had our challenges when it's become the syringe exchange. We've had, the challenges, everybody kind of embraces naloxone. That's not too much anymore. I mean, we're actually seeing the incredible benefits of that in Ohio. And we got it in the car outside. So it's coming around when you can kind of get it into this. I'm giving someone an opportunity for another chance to have a chance to do what I'm wanting them to do. And I want to provide that. And going back to his eloquent point, it's another way that I can love them and I get another chance to help them. And so, putting in that context for me has been helpful for some of our resistant people on the faith side of things.
The question to close the time, maybe going back to this, just the main theme of de-siloing and bridging collaborations, is addressing the polydrug crisis, polysector solutions. So as the overdose crisis grows more complex, particularly with fentanyl, methamphetamine, and even trauma, homelessness, and mental health, no one sector can tackle it alone. Why must our response grow more interdisciplinary, and what are the risks of over-reliance on one approach, clinical, spiritual, or communal?
So, we like to, in our area, talk about collaborate, never recreate. And so we don't have, I would guess all of you, we don't have extra energy. And so, we can't be specialists in everything. So an example of one thing we've done at Her Story is we regularly collaborate with the public health department nurse. So as new people come into our recovery house, everybody gets all the services of public health nurse. And they come to our place, they come to our location. Now for a clinic, that you guys have those there. But again, we have watched our clients get cured from Hep C, HIV go undetectable. I mean, literally, you guys know when the people in recovery trust you, they tell you everything. And the STI situation is no joke. And just this past week, through this collaboration and through the ideas of infusing some wellness, there was a person that went and got all the tests, went and made the appointments, and I saw him a week later, and I said, because I see them weekly, I said, so how are you feeling? And the big thing is I feel like there's a huge emotional burden off of me now because I've had the testing. I know what my results are. I've had my blood, and it's not anything that I really had to do. I just had to collaborate and put in a process in place so that things happen in a routine manner. And I think that's a simple example, and it's so easy. Anyone can do that.
Well, unfortunately, we're out of time. And yeah, again, we could talk for days. And if you want to join on other days, here's a QR code to join our listserv. We'll have monthly gatherings where we continue conversations like these. And again, I really want to thank everyone for coming out and encourage everyone, whether from clinics or church collaborations, to activate. It just takes one champion interested in getting resources and taking each step. And so feel free to email as well. Several resources were mentioned. If you email me, we can connect you with any of those resources or speakers. So thank you again. Thank you to our panelists as well.